Thank you, and good afternoon. I'm Catherine Santoro, Director of Programming at the National Institute for Healthcare Management Foundation. And on behalf of NIHCM Foundation, welcome to our webinar today. At NIHCM, we've been examining rural health in America, and I'd like to share some key points from an infographic we released earlier this fall, illustrating how shifting populations are leaving people behind. The urban-rural divide in America is growing. Only 20% of Americans live in rural areas. Rural America has an older, sicker, and poorer population that faces more challenges in accessing timely care compared to those in urban areas. Many rural areas have lost their hospitals and have fewer healthcare providers overall, as well as fewer primary care physicians, OBGYNs, and dentists. A recent Bipartisan Policy Center poll found that more than half of rural voters say access to medical specialists is a problem in their local community, compared to 33% of voters in non-rural areas. While this paints a bleak picture, there are promising solutions to our nation's complex rural healthcare crisis, leveraging the unique strengths of rural communities. We've convened a prestigious panel of experts today to share their innovative efforts and ideas to reduce rural-urban health inequities. Before we hear from them, I want to thank NIHCM's President and CEO, Nancy Chalkley, and the NIHCM staff who helped to convene this event today, including Kate Ellis, Caitlin Swanner, Harper Schwartz, and Kirsten Wade. You can find biographical information for all of our speakers, along with today's agenda and copies of slides on our website. We also invite you to live tweet during the webinar today using the hashtag #RuralHealth. I am now pleased to introduce our first speaker, Dr. Cara James, Director of the Office of Minority Health at the Centers for Medicare and Medicaid Services and co-chair of the CMS Rural Health Council. Dr. James is a nationally recognized thought leader and expert on health disparities, health equity, and improving outcomes for vulnerable populations. In her current role, she leads CMS's efforts to meet the unique needs of minority and underserved populations. She previously served as the director of the Disparities Policy Project and the director of the Barbara Jordan Health Policy Scholars Program at the Kaiser Family Foundation, where she was responsible for addressing a range of healthcare issues, including disparities in access to care among individuals living in health professional shortage areas. We're so grateful that Dr. James is with us today to provide an overview of federal strategies to address rural health disparities. Dr. James?
Thank you so much, Catherine, and good day to all of you. I'm really pleased to be part of the forum that we're having today and want to thank NIHCM for providing the opportunity to discuss these important issues. And as Catherine mentioned, I'm going to talk today about what we have underway at the federal level. One, I just want to say that there is a lot of activity that is happening at the Department of Health and Human Services around rural health. I'm going to focus primarily on what's happening at the Centers for Medicare and Medicaid Services, but I want you to know that we are working very closely and collaboratively with our colleagues at the Federal Office of Rural Health Policy, CDC, NIH, SAMHSA, and others to improve health care in rural America. So as we start off, one of the things that we have been really focused on at CMS is rethinking rural health. And that is one of our priority initiatives of the administrator that began with our release of our first CMS Rural Health Strategy that we launched last year. And the strategy was developed using stakeholder feedback. We did listening sessions across the country in rural communities such as Pocatello, Idaho, and Rifle, Colorado. But we also talked to rural Americans and beneficiaries to find out what matters to them and what they wanted us to focus on. We then led to the development of 5 objectives that you see here that really focus on trying to apply a rural lens to CMS programs and policies. So thinking about the impact that our policies will have before they're developed rather than waiting at the end to see once they're implemented. Second, we're focused on improving access to care through provider engagement and support, helping our rural providers to be able to meet the needs and provide high-quality care to beneficiaries. Third is advancing telehealth and telemedicine. As you can see, the fourth one is to empower patients in rural communities to make decisions about their health care. And finally, we know that this is not work that we can do alone, so we're working to leverage our partnerships to achieve the goals of the CMS Rural Health Strategy. And that includes those collaborations that are both within the federal family, but also outside, working with states and other community groups to help improve access. In terms of applying that rural lens, one of the things we start with, as many of you are aware, we produce a lot of rules and regulations. We don't do sort of grant programs the way some of our other sister agencies do, but we talk about through our rules how we are addressing our programs and making changes to them. And I highlight this because one of the things as an ask to each of you is to really think about and to provide us with that feedback. We try to get things right. We don't always get things right, but we need your help to improve upon what we are suggesting. So through our rules, we always do a notice of proposed rulemaking where we can get those comments and to feed back into that loop to make sure that what we are putting out really will be helpful to rural communities. We also have, through a number of our programs, we have our quality payment program, and we are so pleased that through our technical assistance, we had a number of rural providers, over 90% of eligible rural clinicians who participated. And while they had a choice of not having to report for the full year, as you can see, more than half of them did in a number of areas, including quality improvement activities, and nearly half who reported for a full year in promoting interoperability. And as you can see, 93% of our rural providers received a positive payment adjustment, and more than half of them received an additional adjustment for exceptional service. I think really noting the high quality care that we see in rural communities by our rural providers. And little difference between those of rural providers in terms of a median score compared to those in larger practice areas. In the space of telehealth, we've made a number of advances. We continue to try and push the boundaries to improve access to telehealth services. So just a little over a week ago, as we finalized our rules for the upcoming year, we added additional codes to telehealth through Medicare to help in terms of a bundle of episode of care for the treatment of opioid use disorders. So these 3 codes start with an initial visit and then provide follow-up as well as additional time associated to help improve access to services through telehealth. We also have added additional services in virtual communication to try and address some of the challenges that we have seen around the ability to do store and forward or remote evaluation, as well as to access services via telehealth outside of a clinical setting. So these virtual check-ins are one of the ways in which we have been able to address that, and we finalized those last year, as well as adding additional prolonged preventive care service rules to the list. In the space of trying to improve competitiveness of some of the hospitals and workforce, we finalized in the summer our hospital wage index, and this is one way to try and level some of the playing field across geographic regions for low-wage hospitals and high-wage hospitals, including many of those that are rural. So we have increased the wage index for those hospitals in the value below the 25th percentile, so that they will have increased by half of that distance to try and close that gap to help support that. We also, in the space of trying to improve workforce and make care more easier for our providers and reducing that burden, we've finalized some changes just in the past week and a half to our direct supervision changes. So this has been a space where we have deprioritized previously the audit of the direct supervision, but we have now finalized a change where we are changing that minimum required level of supervision from direct supervision to general supervision. So we've heard the feedback, and that change is now going into effect. We also provided greater flexibility for physicians' assistants so that absent of state rules, that their current supervision requirement to clarify that physician supervision is a process in which a physician assistant has a working relationship with one or more physicians to supervise the delivery of care. So these are some of the ways in which we're trying to help improve access and workforce, addressing some of those needs in rural communities. We also have a big focus on addressing the opioid epidemic and substance use. And so the CMS Opioid Strategy is a three-pronged approach that includes a focus on prevention, treatment, and data. And we've already, as a result of the SUPPORT Act, implemented a number of provisions, including covering services provided by opioid treatment programs, as well as permitting prescription drug plan sponsors to suspend payments if there's a credible allegation of fraud, and a number of other provisions. And again, in some of the work that we just finalized within the last week and a half, we've added a new Medicare benefit for opioid use disorder treatment. So beginning January 1, we include these services as defined by the FDA-provided opioid agonist and antagonist treatment medications. And one of the things that we want to highlight is that, as you can see for the beneficiaries, there is zero copayment for them in 2020, really trying to reduce some of that financial burden, and also noting that the two-way interactive audio-video communication technology can also be used to try and, again, reach some of those beneficiaries in rural areas. In another couple of areas, just in our innovation, we have a number of innovative models within our Center for Medicare and Medicaid Innovation. So our maternal opioid misuse mom, focusing on neonatal abstinence, as well as our integrated care for kids model, and looking at the integration of behavioral health and physical health, and the new emergency triage, treat, and transport, trying to link in EMS services and helping to treat individuals where they are, as well as our primary cares initiative. And then we encourage everyone to stay tuned, as we have another model that is underway that is focused in rural areas that really will help be a collaborative effort of providers, purchasers, and payers to allow them the flexibility to address the specific needs of their communities. And one of the other areas, we held a forum earlier this year and had participants of one of our colleagues on the phone and a colleague of hers in focusing on how we can improve access to maternal health care in rural communities. So as you can see, between 2004 and 2014, a number of rural counties have experienced closures or loss of their hospital obstetric services. We also have seen a number of hospital closures. So this has been an area of focus that we had starting with that forum and building on that. This is another area where there's a lot of attention in maternal health services being provided at the department level as well, and collaborations that are happening across the agency to address some of those challenges related to maternal morbidity and mortality, and it greatly aligns and works well with the focus as well on rural. So in my last couple of minutes, the other area that I wanted to talk about is that intersection of rurality and health disparities, specifically focused on some of those disparities by race and ethnicity. So in collaboration with the CDC, Office of Minority Health and Health Equity, we've done some analysis of looking at racial disparities among individuals within rural areas, and just in a couple of highlights, we note there are disparities. This shows you the gap in fair poor health, but we also see disparities by geographic distribution. So we know that where you live matters, and as you can see, whereas about half of rural Americans live in the South, for rural African Americans it's 94%, and nearly 60% for Hispanic Americans. For our American Indian and Alaska Native in rural communities, 38% of them are located in the West, where overall it's only about 11% of rural adults. So we know that that matters in terms of services and expansion of access to insurance and other programs. We have as well, looking at that income distribution, we heard earlier, as Catherine mentioned, that in general, rural Americans tend to be poorer than urban Americans, and you can see that within those rural Americans there are some disparities where we have significantly higher rates of African Americans, American Indians, Alaska Natives, and Hispanics who are living on less than $25,000. So we have a tool if you want to play and look at the data at the local level. We have our Mapping Medicare Disparities tool, which allows you to drill down to the county level, and you can see which counties are, the striped counties represent those that are urban counties, and so the solids are ones that are rural counties, can compare a number of conditions. And lastly, we also are focused on work around the social determinants of health. We know that much of what is happening to our health is a result of things outside of the clinical setting. There are a number of frameworks that are being used to talk about the social determinants of health. This is one from Healthy People 2020, but we don't have very good data being collected, and definitely not in a standardized way. So one of the things that we have been working on is how to improve some of that collection and support that. And in our post-acute care rules that we put out earlier this year and finalized just a couple weeks ago with the home health rule, we have begun through our patient assessment to incorporate some collection of social determinants data through those assessments. So that will be rolling out shortly. So that is a whirlwind tour. There is a ton of stuff I was not able to talk about. Hopefully we can get to it in some of the questions, but I just wanted to give you a sample to know that there is a lot of effort and activity that's happening in rural health at the department and across CMS in particular. And if you want more information or have questions, please visit our website or contact us at ruralhealth@cms.hhs.gov. And again, I want to thank Catherine and NIHCM for providing the opportunity to share some of what we're doing, and look forward to the other presentations. Thank you.
Thank you so much, Dr. James, and your team at CMS for your leadership and continued commitment to strengthening the rural healthcare system. Your work that you just shared with us really has the potential to improve care delivery and lower costs, and we're excited to learn more as you test new approaches to support both patients and providers in rural areas. Our next two speakers are leading innovative collaborative efforts to improve access to care in their states. We're now joined by Dr. Mark Jansen, Vice President and Chief Medical Officer for Arkansas Blue Cross and Blue Shield. Arkansas Blue Cross and Blue Shield is committed to serving rural communities by addressing issues related to social determinants of health and improving access to health care. As a leader and partner in statewide efforts, Arkansas Blue Cross and Blue Shield has spurred dialogue and collaboration among key stakeholders to fill gaps in care in rural Arkansas. Dr. Jansen has been a critical part of these efforts, and we will hear today about many of Blue Cross's innovative initiatives. Dr. Jansen brings his own unique experience to our conversation today as a self-proclaimed country doc in Southwest Arkansas for over 3 decades. He also spent the last 6 years educating primary care physicians at the University of Arkansas for Medical Science, both on their central campus and on affiliated regional programs in 8 rural locations. Dr. Jansen has a special interest in rural healthcare sustainability and workforce development, and we're so pleased that he could join us here today. Dr. Jansen?
Thank you very much, Catherine. I appreciate as well the opportunity to present my information to this webinar and also to NIHCM. So you heard a little bit about my background. Yes, I am a self-avowed country doctor, reformed now to the city, but still have rural citizens and rural medicine in my heart, and I'm giving this presentation from that perspective. So Arkansas, back in the 1900s, our state was 90% rural. The rest of the country was 60%. You see the lines before you. There's been a decrease in the rural population where we are now approximately, as of the last census, 44%. About every 2 years, the University of Arkansas Division of Agriculture, Research, and Extension will provide an excellent report. It's available online, the Rural Profile of Arkansas. And in their 2019 report, one of the summary highlights was that the rural areas had only about 70 primary care physicians per 100,000, as compared to the urban areas of the state, which had approximately 170. Family physicians are important in the rural area. We know that only 15% of the production of the workforce is family medicine, but they provide 42% of the care in the rural areas. A busy slide, bear with me. Let me tell you about my research. So this was 2015. I just had a suspicion that we were already looking down the barrel of a physician crisis, particularly in the rural areas. So I went to the Medical Society, got a list of all the self-identified general practice, family medicine, and primary care internal medicine physicians in the state. I then excluded the top 10 most populous cities to create a rural subset and plotted number against age. So the graph that you see before you, if you can't read the fine print on the bottom, the tallest bar in the center is age 60. The cohort, there are 23 in that group, and then you can see right behind that a precipitous fall in the number. Shift all this in your mind 4 years into the future. The 60-year-olds are now 64. They're approaching retirement age, and very shortly we are going to have an issue with that I think is going to be dramatic regarding provider accessibility in the rural area. Oftentimes when this type of crisis occurs, there are various solutions that are recommended, legislative and otherwise, and there may be the impression that things are getting better because you see the bimodal curve start to rise again, only to fall more precipitously after about 16 or 17 years. So we have to do something to increase the number of rural physicians and providers overall in the rural part of the state. Arkansas has what we call the red counties. So this is looking at life expectancy. If you happen to live in the eastern part of our state, which is predominantly the Delta area, your life expectancy has diminished as compared to the longest lived in the northwestern corner by almost 10 years. We traditionally have been number 47, number 48 as far as overall health care and the health of the population per the United States. If you eliminated 10 of these red counties, we'd come up to about number 25. So it really illustrates how significant the disparity is in the rural Delta. Sometime back in 2015, Arkansas Blue Cross Blue Shield gave a $1 million donation, $1.3 million donation to the University of Arkansas for Medical Sciences to create the George K. Mitchell Endowed Chair in Primary Care. Dr. Mitchell is a physician still living, was a former president and CEO of Arkansas Blue Cross Blue Shield, and I was fortunate enough while I was at UAMS as an associate professor to receive this chair. And an endowed chair throws off proceeds that then can be used to do whatever is appropriate on behalf of the holder of the chair. So I elected to approach the Winthrop Rockefeller Institute. The Winthrop Rockefeller Institute is a sister organization of the University of Arkansas, and Governor Rockefeller this was Winthrop Rockefeller back in the 60s, was the governor of Arkansas. There's now an institute utilizing resources from that family to address problems in the state, and I approached them about the issues that we had collectively regarding rural health care, and out of that came the Rural Healthcare Summit. So we had an organizational meeting in 2016, and then in 2017, 18, 19, and again anticipating spring of 2020, we bring together approximately 60 individuals invited, coming from all walks of life. These are providers, both physician and advanced practice providers. We have mayors, hospital administrators, politicians, community health workers. We're really trying to gather a group of like-minded individuals who recognize the problem, and they come together to try to come up with some solutions. Arkansas Blue Cross Blue Shield, through its Blue and You Foundation, has been especially important to this group regarding funding. They've allowed us to perpetuate the program, and also we're able now to invite those who, again, come from the red counties, so the community health workers that might otherwise be financially disadvantaged to attend can now attend with no charge whatsoever. So it's been an important support of Arkansas Blue Cross Blue Shield. So what does this group do? In our last summit from 2019, these were the 2-year goals. Community health workers, this is a marvelous group of folks. Again, it's more rural than urban, and basically they're a grassroots healthcare delivery system that is out in the Delta in particular, but it's very difficult for them to have any formal recognition, so we are working to create a certificate program and acknowledge the contribution as well as provide appropriate training for these individuals that actually go into the homes of folks that need assistance with negotiating health care. As you'll hear, non-emergent transport is a big deal in rural areas. It's hard to get from point A to point B, particularly if you don't happen to have a vehicle or have trouble affording gasoline. So we're looking at legislative solutions to this. The Medical School Consortium Working Group. So there's been the traditional allopathic school, University of Arkansas. We now have 2 schools of osteopathic physicians on either side of the state, and we're looking at ways to increase residency slots to increase the number of rural physicians in the state. We're also having a collaborative come out of that where there's a student organization. We also got the deans of all 3 schools to come together in a collaborative effort. I understand that was the first time that deans of all medical schools of a given state actually work cooperatively together toward a common goal. And then finally, Student Exposure Working Group. And what I'm talking about here is not the traditional high school student. We're going all the way down to the elementary school level, and we're trying to make kiddos in rural areas be aware of opportunities in healthcare, not just the traditional doctor and nurse areas, but coders, laboratory technicians, administrative folks, all the things that are required to run a rural healthcare delivery system. The Winthrop Rockefeller Institute wants to see their children move on to other things, and so their goal is to graduate programs and then move on to other needs in the state of Arkansas. And I will tell you that the Rural Health Summit is beginning to morph into the National Rural Health Association chapter for the state of Arkansas. Oddly enough, we're one of 7 states now that doesn't have a Rural Health Association. And this is a critical deficiency because we, like other states, have real problems regarding sustainability of hospitals in the rural area. DeQueen, Arkansas is a small community in the piney woods of West Arkansas near the Oklahoma border. It closed this last year. As you're well aware, there are a number of rural hospitals, both in the state and in the nation, that are financially challenged. It was mentioned earlier the issue related to opioids, so we have the dubious distinction of having the 2nd highest rate of opioid prescriptions in the nation. Alabama is slightly ahead or behind, depending on your perspective, of Arkansas. And it's a real problem here because despite having an issue, we're also very slow to adopt MAT programs. There's a common opinion in Arkansas that when you look at substitutive therapy with Suboxone, buprenorphine, and others, that this is simply providing one addictive substance in exchange for another. So, and again, that's a backward mentality in my mind, those of you who know the excessive MAT programs, but it's a little bit of an uphill push for us here in the state. As was mentioned earlier, social determinants are more impactful for rural residents. The rural residents tend to earn almost $10,000 less on a per capita basis in the U.S. As was mentioned before, if you happen to be in a minority, this is even more substantial. 25% of children in the rural area live in poverty, and those folks are having to assess the Supplemental Nutrition Assistance Program more frequently. And then tobacco use. I know we've got all the vaping in the news right now, but tobacco use is more common among kids in rural areas, and we have a specific issue with dipping forms, smokeless forms of tobacco, which can create their own set of health problems. We have real and what I'd like to call digital transportation issues. So rural residents have trouble with the distances between their residence and the nearest healthcare provider. They have to travel a long distance. If you are traveling in a rural area, more than 50% of vehicle crash-related fatalities occur. It makes sense. Your velocities are going to be higher in rural areas. Should you be in an accident, the ability to have EMS get to your location is slow because of distance. And then if you know about the golden hour of trauma, the opportunity once you're collected by the EMS service and actually delivered to a trauma center, it's not uncommon for that to take a lot longer than 60 minutes, which increases the mortality rate. And then I want to bring the concept of what I would call the digital desert. So 53% of rural Americans lack access to what would be considered the minimum for high-speed internet, and this is going to create a challenge as we develop these web-based delivery systems. You have to have the opportunity to connect to the web at a reasonable speed to be able to take advantage of those. Behavioral health and mental health is an issue in the rural areas that create unique challenges. Again, those individuals have to travel long distances. They're less likely to have insurance for these services. Just as there are chronic shortages of regular providers, those that have special expertise in mental health are much more sparsely populated. You may be okay to say that you have a therapist if you live in LA or New York, but if you live in LA here, which we call Lower Arkansas, there's a real stigma of needing or reaching out for help for a behavioral health problem. And because the accessibility to care and recognition of these problems is poor in the rural area, it's not surprising that rural youth have a suicide rate twice the typical average. So what do we do about the provider shortage? This was a Pew Charitable Trust article from 2015, and it's recognizing that the solution is not to create more medical students. The solution really is to look at how we create more residencies, because we know that a physician, a graduate from a medical school who stays in the same state to do an accredited residency and becomes board certified has a 68% chance of remaining in that state to practice. So while some states are looking at spending all kinds of money to create new schools, a handful are starting to recognize the criticality of increasing residency slots in rural areas. Let's do a little retrospective look. Iowa, a few years back, graduated 369 students, with 131 leaving the state because 238 positions were available. Missouri lost 186, Tennessee lost 200, and your import states, interestingly, are New York, California, Massachusetts, and Pennsylvania, primarily because those are the states where advanced medical education had its infancy back in the day. What about Arkansas? If every freshman graduates as a senior at UAMS, we graduate 174 students. As I mentioned, we now have 2 DO schools, one on each side of the state, one in Fort Smith and one in Jonesboro, Arkansas. All in, they will contribute an additional 270 students to create a total of 444. Last year, I did a survey to find out how many first-year positions we had in the state. You can see those before you. I won't read them, but we had a total of 217 first-year positions. So, a little math. You've got 444 graduates with only 217 first-year positions. We will, in fact, export 227 students, and that assumes that any student would take any residency position. If I want to be a pediatrician and the only opportunity is a surgical urological position, then I'm going to go elsewhere to get my pediatric residency. A little bit of math to show you the financial impact. All in for fees and tuition this last year, it cost somebody a student in Arkansas $138,627. Fees and tuition only, not looking at housing, transportation, and other things. The actual estimated cost of educating that student is $362,500. So you do the math, you end up with a difference of $223,873. So if you want to think about it, every student in Arkansas that leaves for elsewhere is also taking with them nearly $250,000. What is the financial impact of that to the state? 444 minus 217 leaves 227 times 223.8, $50 million of export for the state of Arkansas. I'm going to finish with digital health because I think that's where it has to go, at least as part of the solution for the rural area. Arkansas was so fortunate back in 2010 to receive a BTOP Broadband Technology Opportunity Grant of $102 million. With that, we were able to create over 450 T1 lines around the state in clinics, health departments, 2- and 4-year universities. We became at the time the most wired state in the nation, and on this network, we've been able to utilize it for the Arkansas Saves Telestroke program. This is where specialists, neurology specialists, will be able to virtually hold the hand of rural emergency doctors who are presented with a patient that has a thrombotic stroke to push lytic agents to recover brain. You can't wait on that. You have to do it at the point of care in the rural area. Dr. Curtis Lowry has developed a high-risk maternal fetal health program to reduce complications of high-risk pregnancies in the rural area. Blue Cross, in the last 2 months, has awarded $1 million once again to UAMS to enhance Dr. Lowry and his team with regard to the digital health enterprise at UAMS. So what's going on with digital health? Blue Cross is in the process of assisting clinics with receiving cameras so that diabetic retinal screening, this is a big deficiency. The typical numbers that I see in clinics is around 30% compliance. And these folks can go blind and not even know they're having a problem. This is low-hanging fruit that I think is perfect for a digital application. In addition to that, there are a number of other specialty services that are being provided around the state. So one that's interesting to me, this is a friend of mine, Dr. Stephen Cannon at Arkansas Children's Hospital. He's a pediatric urologist. Peds urology is a rare bird, let me tell you, and he's been able to work on a project to see small children with urological problems in the rural area of the state from a central location. In addition to that, Arkansas has the first telehand trauma service. So Dr. Wyrick, you see, and her team carry iPads 24/7, 365. If someone shows up to an emergency room in Arkansas with an injury, they can be evaluated virtually right to that rural ER. This saves time, it saves resource, it saves digits, it saves limbs. And if the injury is one that's too catastrophic to be cared for in Arkansas, it can be appropriately referred on to another state specialty. Dr. Teo has a teleburn program very similar to telehand. Someone shows up in the emergency room with a burn. It may look really impressive and severe to the physician or the nurse practitioner out in the rural area, when in fact it really wouldn't qualify to be in a burn unit like we have here in Little Rock. So she's able to guide therapy and, importantly, can keep care that really should stay home at the home facility, enhancing revenue margins and also facilitating convenience for both the patient and the family. The last slide talks about the newest program in Arkansas. It's our Telus Spine program. So we know that there are a lot of folks with chronic spine conditions. A well-intended primary care physician may refer that patient to UAMS for surgical intervention to get the patient out of pain. Patients can travel a long distance in our state to then see Dr. Pate and others, only to be told after the initial assessment that they're really not a good surgical candidate. So we now have trained telepresenters around the state in our regional programs. Those are the rural residency sites, and that can short-stop the patient having the initial evaluation via the web and keep them from coming all the way if they're not a good surgical candidate. It therefore frees up bricks and mortar space to allow those patients that are evaluated at UAMS to be more likely to benefit from surgery if offered. That is the conclusion of my presentation, and again, I appreciate the opportunity to participate.
Thank you so much, Dr. Jansen. As you've highlighted, the problems are complex, but your work's clearly having a positive impact, and we look forward to continuing to learn from the creative solutions being implemented in Arkansas. Our next speaker, Dr. Robert Morrow, is the Market President of Houston and Southeast Texas at Blue Cross and Blue Shield of Texas. Blue Cross and Blue Shield of Texas is tackling the rural health crisis by looking holistically at what influences a person's health. They're implementing forward-thinking collaborations and supporting innovative research to address distance and access challenges in rural communities. Dr. Morrow previously served as the Director of Medical Quality for the Rural and Community Health Institute of the Texas A&M Health Science Center and recently joined their board of advisors. He's held leadership roles in large hospitals and in statewide organizations, including serving as the Chief Medical Officer for Houston's Memorial Hermann Southwest Hospital after practicing privately in family medicine for several years. Throughout his career, he's gained an on-the-ground understanding of some of the unique challenges facing small rural-based practices and rural hospitals as they tried to provide access to health care in their communities. And we're so fortunate to have him with us today. Dr. Morrow?
Yes, well, thank you very much, Catherine. I certainly appreciate the introduction that might have been written by my mother, as nice as it was. I'd like to also thank the previous two speakers, Dr. James and Dr. Jansen, for their remarks, and really appreciative of all the work being done in this space because I think it's critically important. Just as a little bit of to give you the background of where my remarks will be coming from. So Blue Cross and Blue Shield of Texas is a part of the Healthcare Service Corporation, which serves Blue Cross and Blue Shield of Illinois, New Mexico, Montana, and Oklahoma. And as such, the rural health care is extraordinarily not only important to us and our members, but to all the communities we serve. Among those 5 states, we can count well over 1 million of our members that actually exist in the rural areas of the state or of our states. As has already been mentioned, we've got issues to handle in rural healthcare. I've said before that when it comes to healthcare in general and opportunities for improvement, we are living in a target-rich environment. But in rural healthcare, there's even more targets. As noted here, we have demographic issues, declining populations. Both of the previous speakers have remarked about that. Certainly economic problems, limited resources, again, that's been highlighted by our previous speakers, health status and behaviors, and certainly limitations on access to health care. And I'll talk a little bit about hospital closures coming up. Just to put sort of a context around, in part, what we're dealing with, I just thought I'd highlight one of our counties. This is King County. So King County is about halfway between Wichita Falls and Lubbock. For those of you who don't know where that is, that's about a little north of halfway between Dallas-Fort Worth and El Paso. King County has a population of 282, which makes it the 2nd smallest county in Texas, or the 3rd smallest county by population in the country. If you're in King County, you have no clinic, no hospital, no urgent care center. In fact, you have no physician. And the closest access to a physician for you in King County is 60 miles. So if you live in Guthrie, which is sort of in the middle of King County, or if you happen to be driving through King County on the way from one of the locations I mentioned to the other, you're 60 miles away from the nearest care. So I think if for those of us, or for those who live in rural areas, the reason we talk about rural areas and how important access to care is probably obvious. But for the rest of us, what happens in the rural parts of this country are also critically important. That's where we get the clothes we wear, that's where we get the food we eat, that's where we get the energy that powers everything actually that we need energy to do. In Texas specifically, you can see by the numbers noted on here, not only do we get what we eat, where, and how we live with regards to energy from our rural areas, it's also a significant part of our economy. And so what happens in rural areas matters to all of us. In the state as a whole, we've got significant issues. Texas doesn't rank very well in terms of overall poverty. We have significant opportunities to improve education, and we're having worsening infrastructure issues. And worsening, I say that because particularly what's going on in the rural areas in terms of energy and production, as we're getting more and more people moving into rural areas, issues with regards to poor road conditions are becoming even more and more critical. And so these are things that if we're going to assess health care, we've got to talk about these issues and particularly how impactful they are in rural areas. So why are we talking about those issues? Well, it's here. As a physician, I would say it's somewhat humbling to have to accept that in terms of what influences a person's health, what I and my colleagues as physicians or other providers of health care can do only impacts about 20% of a person's overall health. As we have, as has already been discussed this afternoon on this call, it's really the social determinants of the health that are much more impactful for overall health, and I would say much more difficult to address in the rural areas. A more and more common heard sort of catchphrase is that your zip code really is a stronger predictor of your overall health than your genetic code. And if that zip code happens to reside in a rural area of Texas or really any other state, then you are presented with somewhat unique or at least more significant challenges. In terms of Texas specifically, as I mentioned, lots of challenges. Starting from the sort of bottom left of the slide, we've had 138 rural hospitals closed since 1960, which is the most in the nation. We now have about 160 rural hospitals who are still available to care for close to 3 million people. Texas, unfortunately, carries a high burden of uninsured in general, and that is only worse in the rural areas of the state. Texas is also one of the states that has chosen not to participate in Medicaid expansion, which has added some other challenges that need to be addressed. These stats are, Texas has 254 counties overall. And so I like this stat. So 147 of our counties have no obstetrician, which would be like saying, at least from a landmass standpoint, that Nebraska does not have an obstetrician. If you look at mental health, 185 counties have no psychiatrist, which would be like saying Kansas doesn't have a psychiatrist. And 35 of our 254 counties actually have no physician. And to Dr. Jansen's comments about physician age earlier, 1 in 5 rural physicians in Texas is actually over the age of 65. So lots of significant challenges with regards to health care in Texas. So it's going to take a lot of unique and maybe new types of partnership. It's going to take looking at our physician workforce. I share, if misery loves company, Dr. Jansen and I have share a lot of misery together. We also are very supported in terms of physicians. We graduate, despite the number of physicians we graduate, we're 47th in the nation in terms of physicians per capita. Actually, even if you have insurance in Texas, your access to primary care ranks last in the country. So we've got to do things like enhance access to care, expand health literacy and navigation, certainly looking at education outreach, and how do we get our communities more involved. Improving healthcare access through early detection, really finding better ways to deal with chronic disease, and better ways to target and incentivize maybe alternate types of community providers. And then I think innovation and partnership is really where we need to focus. And I'm going to talk a little bit about that in terms of some collaboration that we're working on. This is Dr. Dan McCoy. He's our Texas Plan President. Dr. McCoy is from the little town of Iredell, Texas, which is in sort of north central Texas. I think last census population 332. And he said we need a moonshot, which is an acceptance that just trying to provide care in rural areas the same way we've been doing it for the last 70 years is probably not going to solve the problem. Healthcare, the way we provide healthcare has changed dramatically, particularly over the last 20 or 30 years, and it's hard to just expect that rural areas can continue to provide healthcare the same way and be viable and continue to provide accessibility for their communities. So we're excited to have embarked on a collaboration with the Texas A&M Health Science Center and its Rural and Community Health Institute around what we're calling a Rural Health Moonshot. This is sort of when we kicked off this collaboration earlier this year. And some of you may recognize the lady on the far right of your screen is Dr. Nancy Dickey, who actually was a rural practicing physician, ended up being the first female president of the AMA, and also ran the Texas A&M Health Science Center for a number of years. Currently, she's president emeritus of the Health Science Center and is the executive director of their Rural and Community Health Institute. So we're working on identifying unique opportunities for improving health and access in rural parts of the state. These are some of the things that they will be, that this collaboration will be focusing on. And I'm going to end by talking through just some of the opportunities that the collaboration will be looking at. One, what happens to population health after a hospital closes? These are actually really critical questions because we need to understand the impact on the community in order to be able to have meaningful discussions not only with healthcare providers, but with community leadership around how best to provide access to care in those areas. There is some initial data to suggest that mortality rates in rural populations can go up by as much as 6% after the closure of a rural hospital. Same study in urban areas shows no measurable increase. Another project is actually looking at what happens to the at reestablishing access to care after a hospital actually closes. So the first project will really provide information to help inform this one. So the answer is not typically going to be, well, let's just try to put in another hospital back in. That model has already failed. So what other kinds of innovations? How can we leverage technology, transportation, alternative care delivery models, et cetera, in order to reestablish meaningful access to care after a hospital has closed? The third project, if I can get it to come up, will be how can we use collaboration to preserve access. What this involves is not every county in Texas probably needs or can support its own hospital. And even though a hospital in the county is also an economic engine for the county, the way healthcare is delivered now, it's unreasonable to expect that every county can or should have their own hospital. So this is really looking at how can we get different areas, different communities to come together and agree to collaborate on providing meaningful access to care in their communities. And this is no easy task. And the information gained from the previous two projects can also help inform this one. In some cases, it's hard to get these two communities or their leaders to come together and agree on where to have lunch. And so providing them with meaningful data and understanding of how they can collaborate in order to provide access in their communities is important and to some degree difficult. And the last one is talking about how can we manage chronic disease more effectively in these rural areas. And this is really key. It has already been mentioned. Our rural areas experience a much higher burden of disease than their urban counterparts. And so looking at ways to improve the care of chronic disease in these areas actually lessens the need for them to access a healthcare system that is already stressed and strained. It also provides an opportunity to leverage technology, to leverage maybe other types of workers that are in the community that can be additionally trained to provide care for patients with chronic disease. This, like the others, can be looking at different applications of technology, including things like autonomous vehicles. We've even had discussions about, is there an opportunity to use drone technology and other things like that in order to be more, to provide more access in rural areas. Same digital issues that Dr. Jansen remarked would apply here that would have to also be addressed in that context. So lots of work going on with A&M and other areas to try to find ways to meaningfully impact care in these rural areas, because of course whether you live in Dallas or Guthrie, Texas, we would all hope that we would have access to the kind of quality care that we want for ourselves, our friends, and our family. I'll just end there by commenting we're proud to be celebrating our 90th year as Blue Cross and Blue Shield of Texas. And thank NIHCM for putting this on. Thank my other presenters for their comments and information. I believe that these kinds of conversations are critically important to getting us to where we need to be with regards to rural health care. Thank you very much.
Thank you so much, Dr. Morrow. The evidence generated through the collaboration between Blue Cross and Texas A&M will be critical to inform decisions regarding how we ensure appropriate and timely access to health care in rural communities going forward. Our final speaker, Dr. Carrie Henning Smith, is going to delve into the timely topic of access to maternity care in rural areas. As we've discussed today, hospital closures and the loss of hospital-based obstetric services have had an impact on maternal and child health, and she's studying what this means for the future of rural OB care. She'll also suggest some practical policy solutions. Dr. Henning Smith is the Deputy Director of the University of Minnesota Rural Health Research Center and an Assistant Professor in the Division of Health Policy and Management at the University of Minnesota School of Public Health. She is committed to advancing health equity, and her research focuses on improving the health and well-being of rural populations. We're pleased that she's with us today to share her important work.
Thank you, and thank you to NIHCM for hosting this webinar. I'm really excited to be a part of this conversation. I have the unenviable task of being the final presenter, and I really learned a lot from the first three presenters. Some of what I'll be sharing today will echo some of what we've already heard about access to OB care in rural areas, but I'm going to dive a little bit deeper, and I hope that that's useful for you both to talk about OB care, but also as something of a case study of care in rural areas generally. So before I do any of that, I want to acknowledge my collaborators at the Rural Health Research Center, especially Katie Casamano, who has really been instrumental in a lot of the work on rural OB care, and also our funders, the Federal Office of Rural Health Policy, who've been very supportive of this work. When we talk about maternity care in rural areas, it's important to think about who we're talking about and the context within which that care is provided. So just to ground us in that context, there are almost 20 million women of reproductive age in rural America, and 500,000 babies are born in rural hospitals each year. So this is not a small number. This is not an uncommon thing. We all know people who have given birth in rural areas, I'm sure, and we can relate to this in a personal way. But access to care generally for any type of service is a frequent challenge, as we've heard from the other presenters today. Contributing factors to those challenges include transportation, financial constraints, workforce shortages, and all of the other issues that we talked about today. I also want to put a caveat on everything that I'll talk about from here on out, which is to say that rural areas are not a monolith. They have always been, and they are increasingly so, diverse across a range of markers. And that means that the issue of access to maternity care doesn't impact all communities equally, but has disparate impacts in different communities. And I'll talk a little more about that in just a minute. I want to give us just a sense of some of these numbers, and Dr. James already shared some of these. I'm going to dig in a little more deeply and look to see between 2004 and 2014, what was the scope of obstetric services lost? And I also want to say, because I'm sure some of you are thinking to yourselves, 2014 feels like a long time ago already. So if you're thinking that, stay tuned. We are actively working on crunching more recent data right now, and we expect those results to be ready hopefully within the next several months. Anecdotally, we do know that the losses have continued and that the statistics that I'm going to show you look a little more dire today than they looked even in 2014. So data for this study came from the American Hospital Association Annual Survey, Area Health Resources Files, and U.S. Census data. And using those data, we were able to look across different types of rural counties to see the scope of services and the scope of losses. So looking at micropolitan counties, generally those rural counties with about 10,000 to 50,000 people in them, that's too simplistic, but generally that's about what those counties look like. 82% of those counties had a hospital with obstetric services in it in 2004. That went down a little bit. It went down to about 78% by 2014. But where we really see a lack of services and where we saw the deepest losses were in those rural non-core counties, so our counties with the smallest populations, like King County that we just heard about, certainly a rural non-core county. Those counties started with 40% having hospital-based obstetric services in 2004, and that went down to 30% in 2014. And I'll show you a map of what this looks like. This map is published in Health Affairs if you're interested in digging in and seeing it for yourself. You can see across the country here, the white counties are the urban counties, and so we weren't looking at them. The darkest blue counties are those that had hospital-based obstetric services in 2004 and had lost those services by 2014. Those in kind of the royal or Dodger blue had no services whatsoever during this time period, and those in the teal color had continual services and still had services in 2014. A couple of notes on this map. The places that we are the most concerned are those places where you see contiguous counties lacking services. So it's one thing if your county doesn't have services, but you can drive a few miles over the next county line and get to a hospital with obstetric services. It's another thing entirely if you're in an entire group of counties that's lacking services. And also we know that counties vary dramatically in their size and their shape across the country. So you may be in a county that's very big and getting to the next county is no easy feat. And once again, I want to say that we know just anecdotally that the losses have continued since 2014, and so when we look at an updated map, it would look darker than this one looks. We would see more losses. So in looking to see which counties lost services, we also tried to understand what was associated with those losses. As I said, that rural areas are not a monolith. We know that not all rural areas experienced an equal risk of losing obstetric services. We found that the rural counties that were most likely to lose services were those that had lower birth rates. That makes sense. If you're having fewer babies born, it's certainly harder to maintain that fixed cost of keeping up an obstetric unit if you don't have the census to maintain it. We also found that counties with more Black residents, and specifically more Black women of reproductive age, were more likely to lose obstetric services. That should feel a lot less like common sense. That should feel like structural racism at play right there. We found that counties with lower median incomes were more likely to lose services, and that counties with fewer family practice doctors and OBs were more likely to lose services, some of the workforce issues and the financial issues coming into play there. So all of that may be fine and good if we don't think that there are any consequences from losing obstetric services. But of course we know that there are consequences to losing obstetric services. There are consequences to losing any type of services, and a service where you need to travel when you're in a particularly vulnerable situation, like being in labor and needing to go and deliver a baby, may be particularly consequential. And so looked to see what were some of the consequences, what were some of the changes after these counties lost obstetric services. These results are published in a paper in JAMA if you're interested in looking at them in more detail, because I'm only going to gloss over the results here in the limited amount of time that we have. The data here came from the same sources where we looked to see where there were OB service losses, but we also used birth certificate data to see where people were born. Were they born in the hospital? What did that birth look like? How was the baby doing after the birth? So our outcomes here were a change in out-of-hospital birth, and this might be a planned home birth. This might be a really happy occasion. This also might be an unplanned home birth, or in some situations, a birth on the side of the road. This is much less happy, not a situation that anyone would call ideal. And then we looked to see whether there was a change in births happening in hospitals without obstetric units. This is almost always a birth happening in an emergency room. Someone's showing up in labor and needs to get that baby out. And we looked to see if there were changes in birth outcomes, and we primarily looked to see whether there was an increase in preterm birth or birth before 37 weeks. In the paper, you can read about some of the other outcomes, less prenatal care, increase in cesarean delivery, and low infant APGAR scores. But just to give you some sense of what we found that there was an increase in out-of-hospital births, and this is still a relatively rare occasion, but we found that it doubled from 1% to 2%, and that there was a bigger jump in rural counties that were not adjacent to urban counties. So if you couldn't drive next door to your next door county that was a city with a hospital and obstetric unit in it, you were much more likely to see an increase in out-of-hospital births. And we also saw a significant increase in people giving births in hospitals without obstetric units. And again, that increase was much more pronounced in those counties that were not adjacent to urban counties. This was practically non-existent when counties had hospitals with obstetric units. It jumped up to about 3% after they lost their services. That's not ideal. We know that no hospital staff is looking to have people come in and deliver in the emergency room if there can be another plan in place, and no person thinks of that as their ideal birth plan. And then we found a change in preterm birth. We found just very small changes here, but significant changes. And preterm birth is the #1 indicator of, or the #1 risk factor for infant mortality. It's associated with risks of all sorts of other outcomes that we want to be able to avoid. And so even a small increase in preterm birth here is something to be really alarmed by and concerned about. So overall, we know that rural residents experience health disparities. We've heard a lot about that this afternoon already. And we know that not all rural people and places have the same opportunities for health. There are disparities across rural places, across rural people. But I would say that addressing maternity care as one of many issues that we want to focus on is vital for ensuring the health of parents, children, and the next generation of rural residents. And I'll give just a few ideas of where I think we may want to focus efforts moving forward. On the federal policy level, there's a bill that became a law just at the end of last year called the Improving Access to Maternity Care Act, and that's really focused on improving access to workforce, so getting more workforce in maternity care deserts. There's a bill that's currently in Congress working its way through the Rural Maternal and Obstetric Modernization of Services Act, which has a handy acronym, the Rural Moms Act. Again, that focuses on workforce, but it focuses on a whole bunch of other things too, supports for healthcare systems and families and communities to comprehensively address this issue. And then a federal policy effort, the Quality of Care Act for Moms and Babies Act, which is meant to improve quality and think about how we are analyzing and looking at the quality of care provided. in maternity care. And so I think the federal policy efforts are really, really important. They're vital, they're needed, but we can't only look at those. We also need to think about state and local efforts to address maternity care issues in rural settings. No discussion of rural maternity care would be complete without talking about Medicaid, which plays an outsized role in funding births in rural areas in particular. And so thinking about Medicaid policy and Medicaid reimbursement rates that make it possible for healthcare systems to stay in the obstetrics business even when they have a low census is really important. State scope of practice laws are really important when we think about advanced practitioners, midwives, what are they able to do, how are they trained, what can they safely do, and how can we use them to improve access to maternity care. I'm just whipping through these. We could spend hours talking about any one of these here, and I'm sure some of you have already done that, but I want to just get a sense of some of these on your radar. And then in terms of additional state and local efforts, we've heard a lot about how we get a homegrown rural workforce and how we incentivize workforce to practice in rural settings. That's definitely as important for maternity care as it is for any other healthcare service. Education and trainings and rotations that include obstetrics in rural areas. We already heard a little bit about residencies. That's so important. University of Wisconsin has been doing some really groundbreaking work in this area. How do we build capacity and training, especially thinking about those hospitals with very low volume, very low census, or those hospitals that have lost obstetric services but know that they may encounter a birth in the emergency room? How are people able to maintain their training and their competency in dealing with birth when and if it comes along? Telemedicine for obstetrics, what are the opportunities here for interacting with specialists remotely or for using technology to bridge some of these gaps? Not all. I think there are limits to what we can do with technology, but there's a lot of promise here for filling some of the gaps. And then training for law enforcement, EMTs, paramedics, and other first responders who might encounter births, especially knowing that we have an increase in people giving birth out of the hospital. Insurance regulations and costs. Malpractice insurance is certainly a big issue here, and whether or not that's affordable for rural hospitals is something of an open debate. And then finally, I think that we can't talk about this issue without talking about the impact on rural families themselves. And so are there supports in place? Is there housing or transportation subsidy in place for people who need to travel to give birth? Is there paid family leave if someone needs to leave children at home and travel to give birth for someone else and go back and forth between? I really don't think we do this issue justice if we only focus on the healthcare sector without talking about the families themselves. And I think that I am going to wrap up there with one aspirational goal here, which is to say that we are really, all of us, I think all the presenters on the call are working for workable solutions to the challenges that all rural communities face to improve access to care and quality of care, really with the ultimate goal of improving the health and quality of life of rural communities. So thank you, and I look forward to the Q&A here.
Thank you, Carrie. As you said, I think that sentiment's echoed by all the speakers today to focus on workable solutions. And I know our audience is eager to continue to learn from you all, so let's start our Q&A session. If all the speakers would like to come off mute, and the audience can continue to submit questions online, and we will get to as many as possible in the next few minutes. I wanted to start with going back to Dr. Jansen's presentation. I had a question for you that, as a payer, how do you work with physicians to build the telemedicine network for these various programs? Does each site have its own connection to the virtual specialists, or are all sites able to connect to the central hub for these services?
At this time, we don't have a robust telemedicine connectivity in Arkansas as relate to clinical services. One of the reasons we gave the grant to UAMS is that they are in the process of putting together a system of care delivery utilizing telemedicine. I've been a proponent of telemedicine since 2000 and 10, 15, somewhere, say 15 years ago maybe, and I really think, and I'll keep my answer brief in the interest of time, I think when you start to look at value-based payment models and you look at what telemedicine can do, it's one of the less expensive ways that you can get good care to folks. And as it relates to specialty care services, as I demonstrated with the Telus spine, it is also a way that you might be able to get a higher level of sophistication out to the rural areas. But we're in an infancy. We're starting to change our codes as far as what we pay for. We now have unrestricted 99250 is the code for teleretinal screening, and that's now an approved code in our system for all providers in the state.
And this is Bob. Can I add to that a little bit?
Sure.
Yeah, I would just sort of echo what Dr. Jensen said. Access to telemedicine, particularly with some of our broadband issues, is problematic. However, and telemedicine in general has been a bit slow to be taken up by a lot of folks. One of the things that they're looking at through the Project 2 that I mentioned with the Texas A&M is at least establishing telemedicine access in some community location where broadband is available, so that while the next hospital may be 60-plus miles away or the next clinic 60 miles away, somebody can travel a much shorter distance to get access to an appropriate telemedicine kiosk, if you will, and that may be one of the solutions that may prove to be beneficial.
That's great. Do any of the other speakers want to comment on that? And also just a broader question, like the barriers to expanding broadband and therefore telehealth access, as well as strategies to increase access.
No, this is Cara. I think the only thing I would just reiterate is that the FCC does have, sort of a broadband program to try and improve through some of the grants access to broadband to expand that. But I think there are a number of challenges, and also there's some issues around for telehealth and some around state licensing and some of those barriers. So working at that state level to try and address some of those to help improve that access through that space is a number of things that are happening out there.
Thank you. We had a few questions come in related to access to mental health, and some questions curious how you're addressing access to mental health in rural areas, whether it's through telehealth or other emerging solutions that can help close the gap that we've talked about between supply and demand among rural populations.
I'll go ahead and take that one then. This is Jansen. So if you look historically at telemedicine care delivery, telemental health is probably the furthest advanced as far as being utilized. The VA system in particular has used telemental health very successfully for veterans. So in Arkansas, we are starting to look at the potential of incorporating telehealth care delivery for MAT, because there has been, as I mentioned, the resistance in the state. So can we utilize some resources that might not be available, particularly not just from a standpoint of waivered physicians, but more the behavioral health side of that. And then in my former position where I was working with regional programs at UAMS, we did develop an interconnected behavioral health network with LCSWs in each of the 8 sites where both care provision and training is occurring for rural residents. And in that setting, it was interconnected where any LCSW could see the patient of another one with a warm handoff from the provider in the clinic to the LCSW that would establish care, and then further care could be provided via the web from Little Rock, say, to Helena, Arkansas, which is right smack dab in the middle of that care desert in the eastern part of the state.
Great, thank you. We've had a lot of workforce questions, so I'm going to try to summarize into just a broad question about what you each might see as, the most promising solutions in terms of thinking about non-physician providers and supplementing or replacing physicians in rural health care. And a follow-up question is just if there's any research about are there better outcomes in the rural areas that have been able to have broader scopes of practice?
Well, this is Bob. I can take a little bit of a stab at that. I think, we, like Dr. Jansen highlighted in Arkansas, have a particular issue with getting particularly physicians to go and practice in rural areas. And there's data in my understanding suggests that it's also difficult to get other providers to practice in rural areas as well. But part of the problem is it's sometimes hard to expect a young person to go through all their training with all the bells and whistles and technology that they have access to during their training, and then go into a rural area where basically a lot of what they have experienced is not available. And that's why I think focusing on different types of innovative solutions to how care is delivered in these rural areas, where it becomes more attractive to physicians and other healthcare providers to actually practice in those areas. So I think that's critical. And then I think the other part of that is from a policy standpoint, a regulatory standpoint, us finding ways to make sure that we are leveraging other healthcare providers to the extent of their training and capabilities and empowering them to be effective in these rural areas through whatever innovations we're able to identify as effective, I think is going to be critically important.
And I'll just say there are two states you might look at for examples of how it can be done. First, in the state of Mississippi, Christy Henderson, who's been very progressive. She's a doctor of nurse practice and has been progressive in the telemedicine area. She basically established the telemedicine network. Mississippi has very many rural emergency rooms that are actually staffed not by physicians, but rather APRNs. They have a very robust protocol-driven as well as direct telemedicine collaborative communication back to the University Hospital in Jackson. So that's one thing that's being done with APRNs. Wisconsin has a very robust APRN service where APRNs go out under a collaborative arrangement into the rural areas of Wisconsin and work sometimes just a weekend, maybe 2 or 3 weeks. It's been favorably received, and I think they have a lot of data to show that's been an excellent use of provider extenders to then deliver higher quality care in that state.
And this is Cara. I would just kind of reiterate of the points around trying to improve some of the flexibilities. It's exactly some of the reasons that we have made the changes that we have with regards to the direct supervision, as well as the greater flexibility for the physician assistants to help allow for those providers to be able to practice to the top of their license and to increase that access to care and remove some of those barriers that have been in place beforehand. And I think just reiterating that some of the programs that Dr. Morrow was just mentioning, in particular the Wisconsin program, and the work that they have done to kind of increase access to providers and have some findings as well that show that those providers are more likely to stay in those communities.
Great, thank you. Dr. Morrow, you talked a little bit about starting to think about alternative sites of care, and would be curious to get everyone's opinion on the opportunities for thinking about alternative care delivery sites in the communities with hospital closures, and a specific question about the shifting role of pharmacies in rural health care and the impact of closures of pharmacies for rural health care.
Well, so this is Bob. I don't know if you want me to start out. So very interesting, because the problem, as you just alluded to, in a number of these areas where hospitals and or clinics are closing, they're also losing access to pharmacy. And so it's limiting options if you can provide telemedicine or some other technological solution to access However, your access to a pharmaceutical is still 60 plus miles away. And so this is very, very sort of boilerplate, but if you were able to establish something like a kiosk somewhere where somebody could travel a limited distance in order to get reasonable, at least telemedicine access, would there be an opportunity to have a pharmaceutical dispensing mechanism in that same location where common and typically needed pharmaceuticals that probably not prone to abuse, but reasonable pharmaceuticals could also be dispensed electronically. There might be opportunities to explore options like that because, as I think you've alluded to, it's limited usefulness if you provide access via something like telemedicine to a clinician, but don't have access to the treatment that clinician might recommend.
This is Jansen. I think sustainability of local pharmacy access is critical. Again, being from a rural town with a rural practice of 30 years, I know the pharmacy down the street dispensed tons of medical information that was very accurate. A lot of rural folks will oftentimes seek, particularly if they don't have access to Dr. Google, they will go to their pharmacist first, and that's a trusted source of medical information. My guidance is that we try to look at how we might support pharmacies that are in areas that are losing clinics or hospitals so that they continue to be a reasonable evidence-based outpost for medical care delivery.
Absolutely. Could not agree more with that.
Great. A great question about how we can really build on the positives that are unique to these rural communities, and how do we really build on their resilience, the relationships, the traditions, and use some of those opportunities to help ensure the sustainability of change.
I think that's a great comment and/or question. I think these communities have some significant strengths that can be built on. As I mentioned, we've got 160 rural hospitals still in Texas, and if you've seen one rural hospital, you've seen one rural hospital. And their communities are all unique. They all have their own culture. And a number of the projects that we're working with A&M on are really about trying to identify those aspects of the community that can really help empower those communities to really participate in providing access to the members in their communities to health care. And so that's why I think the data that's being gathered through these projects that can then be shared with the communities and the leadership in the communities is critical, because empowering them in their own solution not only makes common sense, but it also allows them to leverage their unique strengths and capabilities in meaningful ways.
This is Jansen. I know we're approaching the end of our time. The students don't understand all the positives of a rural practice, particularly the relationships that are available there, the opportunity to practice all of your skills and not just simply be an urban referral site to other specialty physicians. It takes a special spirit to be a rural provider, but the Rural Health Summit has sponsored field trips where we have buses of students and their significant others going out for 2 days into rural Arkansas. And that I know we've got at least one or two participants that have now agreed to practice in rural areas primarily because of what they were exposed to during those trips. You just have to get somebody who might come to show up the first time. That's the hard part.
This is Carrie. I will just quickly make another plug for work that we're doing here. We're looking right now at successful models of maternity care in rural areas across the country. And I'll say we're seeing unbelievable strength out there, and creativity and resourcefulness and flexibility, all of which I think rural areas are particularly good at and have particular strengths in. So stay tuned. We'll be highlighting some of those models over the next year or so, too.
Great.
And just to close, this is Cara quickly, I think there are a number of activities, and I think that one of the pieces of that is trying to figure out how to both share those lessons in broader context, as well as supporting the sustainability of those. There are a number of those that may have been started by a combination of grants or grant programs, and I think thinking through how that sustainability can be implemented so that it isn't something that would have to stop. It would be great.
Great. Well, thank you all for those closing comments, and thank you for taking time to be with us today, both to our speakers and to our audience. Your feedback is important to us. We hope you'll take a moment to complete a brief survey, which can be found on the bottom of your screen. We also invite you to view NIHCM's infographics on rural health and social determinants of health. They're available on our website, and we'll also be releasing an infographic on mental health this week. Thank you all again for joining us today.